Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. Designed to enhance reader convenience and the overall KJR experience, SummaryCast provides conversational audio overviews for time-constrained listeners and mobile-friendly learning. This recording was created using a combination of AI tools with oversight from the KJR editorial team or the article's authors, including necessary edits and corrections. For the most accurate and complete information, we encourage you to also read the original published article.
Welcome to SummaryCast.
Today we're looking at a study that puts hard numbers on a risk that's always top of mind in the CT suite, especially when the patient is a child.
Exactly. This is Acute Adverse Reactions to Nonionic Low Osmolar Iodinated Contrast Media in Children, a retrospective study of 23,429 injections over 6 years. It's forthcoming in a 2025 issue of the Korean Journal of Radiology.
A big data set on pediatric contrast reactions. What was the core problem they were trying to solve?
At a high level, the researchers wanted to do two things. First, to precisely measure the incidence of acute adverse reactions in a large pediatric population, and second, to identify the specific risk factors that predict them.
Right. We know anecdotally that reactions are less common in children than in adults, but a lot of the existing data comes from smaller studies, which can make it hard to get a stable estimate.
You nailed it. This study's strength is its scale. They conducted a single-center retrospective analysis, but it was massive. They started with nearly 49,000 pediatric CT exams.
Okay, and how did they winnow that down to the final cohort?
They applied some clear exclusion criteria. They removed over 22,000 unenhanced scans, which makes sense. They also excluded a small number of exams where the contrast wasn't given intravenously or where data on the type of contrast was missing.
So they ended up with a very clean data set of just contrast-enhanced CTs. What was the final number?
It was 23,429 exams in over 13,000 individual patients. All patients were 18 years or younger, and the data covered a 6.5-year period from early 2016 to mid-2023.
That's a solid foundation. Let's get straight to the headline numbers. What did they find for the overall incidence?
They split the reactions into two main categories, as is standard: allergic-like and physiologic. For acute allergic-like reactions, the overall incidence was 0.89%.
Just under 1%. And how did that break down by severity?
It was overwhelmingly mild. Of that 0.89%, the vast majority, 0.79% of all injections, resulted in mild reactions. That left just 0.07% as moderate and only 0.02% as severe.
Got it. So a severe allergic-like reaction is a very rare event. Did the incidence vary depending on the specific type of contrast agent used?
It did. The three most used agents were iomeprol, iopamidol, and iohexol. Iohexol and ioversol had slightly higher reaction rates, around 1.2%, while iopamidol was lower at about 0.5%.
Interesting variation. And what about the other category, physiologic reactions?
The incidence there was even lower at 0.55% of all injections.
And again, mostly mild?
That's right. Mild physiologic reactions accounted for 0.50% of the total, leaving a very small fraction, 0.04% moderate, and 0.01% for more serious events.
Okay, so the top-line finding is reassuring. These are rare events, and serious ones are rarer still. But the real clinical utility here is likely in the risk factor analysis.
Exactly. The multivariate Poisson regression analysis was designed to isolate the factors that independently predict these. Two factors stood out with very strong signals.
Let's take them one at a time. What was the first one?
The first was patient age.
Older children have more reactions?
Yes, the risk increased steadily with age. For every 1-year increase, the adjusted relative risk of an allergic-like reaction went up by 9%. For physiologic reactions, the risk increased by 4% per year.
That paper breaks this down into age brackets, right? What did that look like?
It's a pretty stark difference. For allergic-like reactions, the incidence in children under 2 years old was just 0.2%. It then jumped to 1.3% in the 2 to 12-year-old group before settling at 0.9% in those over 12.
Wow, that's a more than 6-fold increase between toddlers and school-age children. That's a very clear signal. What was the second major risk factor?
The second one was, perhaps unsurprisingly, a prior history of a reaction to contrast media. But the magnitude of the effect was really striking.
Quantify it for me.
For allergic-like reactions, having a prior history increased the adjusted relative risk by a factor of 3.62.
3.5 times the risk. That's a significant jump. And for physiologic reactions,
The effect was even more dramatic. A prior physiologic reaction boosted the risk by a factor of 7.44.
wow, over 7 times the risk. That's a massive signal in the data. It really underscores just how critical a thorough patient history is.
It absolutely does. But the analysis also serviced a more puzzling finding related to the patient setting.
Okay, let me guess. Sicker inpatients are more fragile and therefore have more reactions than outpatients?
It was the opposite. Allergic-like reactions were significantly less common in inpatient or emergency settings compared to outpatient settings. The adjusted relative risk for inpatients was 0.64.
Wait, so outpatients had a higher reaction rate? That feels counterintuitive. What's the proposed mechanism there?
The authors offer a few hypotheses. One is potential confounding. There could be underlying differences in age distribution, comorbidities, or even examination workflows between the two groups.
That makes sense. But what else?
Another idea centers on information gathering. Think of a busy outpatient clinic versus an inpatient setting.
You're suggesting that in the rush of an outpatient schedule, there's less time to conduct a detailed medical history, so critical risk factors might be missed more often?
That's one of the possibilities raised. They also note that differences in workflow and examination procedures could influence how allergic-like reactions are identified.
It's a curious finding. Definitely a signal that merits more investigation to untangle the cause. Before we move on, let's circle back to the physiologic reactions. Were there any unique risk factors for that category?
Yes, and this is another interesting part of the analysis. The type of CT examination itself seemed to matter. Specifically, patients undergoing heart CTs had a significantly lower incidence of acute physiologic reactions compared to those getting abdomen and pelvis CTs.
A lower incidence for heart CTs? That's also unexpected. Cardiac exams are often complex. Why would the risk be lower?
The authors dig into this, and it seems to be a classic case of confounding. The key is that the patient populations for these exams are very different. The mean age for heart CT patients was just 3.5 years.
Compared to what for abdomen and pelvis?
Much older. The mean age for that group was over 10 years. And we already know that older age is a major risk factor.
Got it. So the type of exam is likely just a proxy for the patient's age. It's not that the heart scan itself is protective.
Precisely. The paper also notes that the contrast protocols with different, higher concentrations of LOCM are typically used for cardiac imaging. So it's a tangled web of age and protocol differences, not a direct causal link to the body part being scanned. A very neat piece of analysis to uncover that.
It is. It really highlights the importance of looking for those hidden variables. Okay, let's pivot to one of the most practical questions for clinical practice: managing patients with a known prior reaction.
Right. What do you do on the repeat scan?
Exactly. Does switching to a different type of contrast agent actually help reduce the risk of another reaction?
They were able to look at this directly. They identified 226 examinations performed in patients who had a previously documented allergic-like reaction.
And they split them into two groups, one that got the same agent again and one that got a different one.
Precisely. In the group that got re-exposed to the same generic LOCM, the recurrence rate was 7.26%.
Okay, 7.26%. What about the group that was switched to a different agent?
In that group, the recurrence rate dropped to 3.92%.
So switching the agent appeared to cut the recurrence risk by nearly half. Was that difference statistically significant?
It was not. The p-value was 0.28. The number of events was small, so the analysis was likely underpowered to detect a statistically significant difference.
So we have a trend, but not statistical proof. But did they look at the severity of those reactions? That seems just as important.
This is the crucial detail. Of the 9 reactions that occurred with the same agent, 3 of them, a full third, were moderate in severity.
And in the group that got a different agent?
In that group, of the 4 reactions in that group, all 4 were mild.
That's a very important finding. Even if the overall recurrence rate difference didn't hit statistical significance, the severity profile appears much more favorable when a different agent is used.
You nailed it. It strongly suggests that substituting the contrast agent is a very prudent strategy, not just to potentially lower the chance of a recurrence, but to mitigate its severity if it does happen.
That's a practical and valuable piece of data. Now, what about the role of premedication? It's a cornerstone of managing high-risk patients.
It is. They analyzed its effect as well. They looked specifically at the group of patients with a prior history of an allergic-like reaction who received premedication, which typically involved antihistamines with or without steroids.
And what was the breakthrough reaction rate in that premedicated group?
It was 6.4%.
6.4%. Let's put that in context. What was the baseline reaction rate in the general population of patients in the study who had no prior history?
The baseline rate for those without a prior history was 0.84%.
Yikes. So even with premedication, a patient with a prior history still has a risk that's nearly 8 times higher than that of a low-risk patient.
That's right. The takeaway is that premedication is an important mitigating tool, but it is not a guarantee of safety. It doesn't eliminate the underlying risk.
Which means those patients still require heightened awareness and close monitoring during and after the injection.
Exactly. It's risk reduction, not risk elimination.
Okay, this feels like a good point to discuss the study's limitations. As you mentioned, it's a retrospective analysis from a single center. Let's start there. How does the single center design affect things?
It introduces a potential for limited generalizability. The specific patient population at this one large medical center might not perfectly reflect patient populations elsewhere. The same goes for their specific CT protocols, the brands of contrast they stock, and how their nursing staff is trained to document reactions.
So another hospital might see slightly different rates just based on their local practices.
It's possible. The other big caveat is ascertainment bias, or how the reactions were detected and recorded. The study relied on a prospectively collected database, but the initial reporting of symptoms was passive. It depended on patients or their caregivers noticing something and telling the nursing staff.
So mild, transient reactions could easily be missed or underreported. This seems especially risky in very young or nonverbal children who can't clearly articulate symptoms like itching or nausea.
Precisely. The true incidence might be slightly higher than what was captured. There's also subjectivity in the classification. The paper notes that when the distinction between a physiologic and an allergic-like reaction was ambiguous, the protocol was to default to classifying it as physiologic.
Which could slightly deflate the allergic-like numbers and inflate the physiologic ones. And the low overall incidence, while great news clinically, also presents a statistical challenge.
Right. It makes it very difficult to achieve enough statistical power for some of the most interesting subgroup analyses, like the question of using the same versus a different contrast agent.
That makes sense. So with those caveats in mind, let's land this. If you had to distill this paper down to its essential takeaways for a practicing radiologist, what would they be?
I think there are 3 clear practical points. First, this study provides a robust, large-scale confirmation of what we generally believed. In children, acute adverse reactions to modern contrast agents are rare, and the vast majority are mild. The all-cause allergic-like reaction rate is less than 1%.
Okay, that's a solid number to have for context and for counseling families. What's the second point?
The second is that the risk is not uniform. The analysis clearly identified 2 powerful predictors: older age and, most critically, a prior reaction history. The risk amplification from a prior reaction is substantial and can't be ignored.
Which reinforces the fundamental importance of conducting a meticulous safety check and history before every single contrast-enhanced study.
Exactly. And that leads to the third takeaway, which is about how to manage that identifiable high-risk group. The data suggests 2 things.
Okay.
1, premedication is helpful, but it's not a magic shield. These patients remained at elevated risk. And 2,
For patients with a known prior allergic-like reaction, switching to a different generic LOCM is a very reasonable strategy.
Right. The data suggests it may not only reduce the frequency of breakthrough reactions, but perhaps more importantly, their severity.
Precisely. So the core message is one of reassurance combined with targeted vigilance.
The bottom line seems to be the overall risk is low, but for a specific subset of pediatric patients identified by their age, and crucially, their history, a higher level of caution and a modified approach are clearly warranted.
You nailed it. It's about being prepared and tailoring the approach for those high-risk groups.
A very clear and clinically useful message from a large-scale observational study.
And that's a wrap for this episode of SummaryCast.